ये नहीं लगेगा ना, लगेगा क्या? हाँ. So, good morning one and all. So, welcome to today's class. Again, after second wave of COVID pandemic, we are starting our class in a fresh mood. So, today we are going to discuss something about cards. That is ARDS, Acute Respiratory Distress Syndrome. I'll be touching every basic. I'll not go anything beyond basics. The reason being, we are managing so many ARDS cases. We have been managing so many ARDS cases in the last 6 months. So we should know how to troubleshoot a ventilator, how to manage a ARDS case. So this is called as CARDS. CARDS is COVID ARDS. So we will be discussing on ventilator management of the COVID ARDS. Remember that it is not enough to do your best. You must know what to do. Then only you can do your best. So you have to know each bit and corner of your management skills so that you can give best to your patients. So we will be going through diagnosing ARDS, ventilator strategy. We will be focusing mostly on low tidal volume strategy, the components and troubleshooting, and ancillary care of unintubated patients, because we have seen so many patients lying here in the ED floor for 4 days, 5 days, 7 days in an intubated condition. So how to give sedation, analgesia, neuromuscular paralysis, nutritional care and other supportive care. So again the class will be mostly based on discussion. So Berlin definition of Berlin definition of ARDS and COVID-19. So you all be knowing about COVID-19. What are the diagnosing? What are the screening criteria, diagnostic criteria? So what about Berlin definition? Rahul, start. What is Berlin definition of ARDS?
Sir, acute onset respiratory illness onset within 1 week, and new onset respiratory infiltrate that is not explainable by any pulmonary edema or cardiogenic or non-cardiogenic, and other criteria is PF ratio is less than should be less than 300.
Okay, so we'll again refine the definition. Please tell me about the timing. You have told that it should be within 1 week.
Yes, sir.
What else is there? What is another point that is to be added to that? Acute onset illness within 1 week. What?
Yes, sir, if the patient is having chronic illness and acute
Exacerbation. Yeah. That 1 week of worsening of the symptoms is important. Then what about chest imaging?
bilateral pulmonary infiltrate, sir.
What does that mean? It can be seen in cardiogenic pulmonary edema also.
Yes,
it can be seen in co-workers pneumonia also.
That could not be explained by cardiogenic pulmonary edema.
You cannot see on the images, no. What is Devans? On chest imaging, what is there? What is an important point? Bilateral opacity is not explained by what all things? One thing, Berlin definition of ARDS, everyone has to remember every single point of Berlin definition of ARDS. Everyone. So what else? It should not be explained by effusion, lung nodules or lung collapse. Okay. Third, cause of edema is respiratory in origin. Surya, what is extra point added here? That was the earlier one. Like in 2000s, that was the definition.
In modified Berlin, it should not be cardiac origin and can be
Yeah, that should not be cardiac failure or fluid overload. How to diagnose it?
on echo, EF should be normal.
On the basis of?
On the basis of imaging like echocardiography. On the basis of echocardiography, the EF will be normal.
Okay. Anything else? Any marker you can use?
BNP can be.
BNP can be used. We'll discuss that. Rakesh, what about oxygenation? What is an important point here?
So it is classified into like mild, moderate, severe.
No, PF ratio should be less than equal to 300.
With peep of 5 centimeter.
With peep of
5 centimeter.
centimeter or millimeter?
Centimeter.
5 millimeter mercury. Or else CPAP of 5 centimeter water. Okay. So how to classify mild, moderate, severe?
Sir, mild is like 300 to 200. Moderate is 200 to 100 and severe is less than 100.
Thank you. So the point is like Berlin definition of ARDS, everyone should be by heart this definition because this is very important. Though the definition has so many flaws in itself, but you have to remember because in exams or whenever you are diagnosing clinically, you have to apply the Berlin criteria. Now, use the terms carefully.
Any specific reason why CPAP or the PEEP was added?
Because that much, at least that some amount of lungs to be recruited, and that is a standard definition for them. Means PF ratio at a PEEP of 5 means that is a standard.
So they want to recruit most of the alveoli,
Yeah.
some of the alveoli at least.
At least.
Actually, they wanted to say that the FiO2 is only predictable when PEEP और CPAP is 5.
Okay.
उसके बाद उससे उस पे अगर FiO नहीं कर सकते फिर.
So use the terms carefully. You have been diagnosing many of our JRs have been writing severe ARDS, severe COVID ARDS. So those two things are different. Means severe COVID versus severe COVID ARDS, because severe COVID according to WHO definition it is a different thing. Mild, moderate, severe or critical. But severe COVID ARDS means severe ARDS. PF ratio less than equal to 100 millimeters of mercury at a PEEP of 5. Now about the lab parameters, what we will be sending is one arterial blood gas, obviously, complete blood count, blood chemistries, that is as a part of routine. As Surya has said, to rule out cardiogenic causes of pulmonary edema in ARDS, yes, you may try using POCUS or you may try using a lab test that is called as BNP. Anyone can tell about breathing not properly trial? Aditya, what is BNP trial? No idea. So anyone else? Okay, so breathing not properly trial, what they have told, that trial was published in AIIMS nearly 2000s, and what they have told that to rule out cardiogenic causes of pulmonary edema, yes, you can do BNP, but the point is it has to be done in ED in only cases of dyspnea where you are not clear whether it is a pulmonary cause of bilateral lung infiltrates or cardiac cause of bilateral lung infiltrates, and from there you have got this cutoff points like how to when to rule out heart failure or what is the higher cutoff that heart failure is likely. So we have to remember this values also. Now on the imaging, we have been using every time day and night in all the patients that point of care ultrasonography. Before that, if chest X-ray is available, yes, you can do. If bilateral lung infiltrates is there, it can go it goes in favor of Berlin definition, but it should not be explained by the bilateral pleural effusion. Here you can see pleural effusion, so this should not be there. Then coming to ARDS versus cardiogenic pulmonary edema, everyone must have done in last 1 year at least how to differentiate ARDS versus cardiogenic pulmonary edema. Sina, how to differentiate ARDS versus cardiogenic pulmonary edema on the basis of bedside lung ultrasonography?
Pleural line will be thickened and shred will be visible, subpleural shredding will be visible. While in cardiogenic pulmonary edema, pleural line will be fine and we won't be able to see any shred. There will be pure pulmonary edema, therefore we will be able to see only B lines.
Okay, anything else?
Anything about that spacing of the B lines?
Yeah, there will be clustering of B lines in ARDS, while cardiogenic pulmonary edema uh, the B lines will more be scattered and spacious.
Huh. So now I will cover otherwise. So these are two pictures. One on the left side, this is a picture of ARDS, whether this is a picture of cardiogenic pulmonary edema. Here you can see a sparing, and here if you are seeing, here we are not seeing clearly, but there are lung spare areas. So in our study in previous year only, we have defined what is lung sparing. In one rib space you might be seeing the B lines, but in next rib space, in intercostal space, you might not be seeing the B lines, but again in another lower intercostal space you will be seeing. So that is called as lung sparing. Something else, like as Sina told about the pleural lines, pleural line thickening is there. It should be more than 2 mm as per for research purpose only, but yes, pleural line thickening or irregularity should be there in ARDS, whereas in cardiogenic pulmonary edema it should be very plain and uniform, smooth. Another thing is like subpleural threading or subpleural consolidations are findings of ARDS, whereas in cardiogenic pulmonary edema it is not. And in ARDS you can see consolidations, air bronchogram, and a small synpneumonic parapneumonic effusion, whereas in cardiogenic pulmonary edema it will be completely it will be a bigger pleural effusion, and subpleural consolidations may not be there, though the collapse consolidations might be a finding. So we cannot differentiate on the basis of that. In ARDS, yes, bilateral threads should be there, bilateral threads should be there, bilateral pleural thickening, pleural irregularities, spared lines, waterfall sign. What sir was asking is about the confluence of B lines. That is called as waterfall sign. Some of the studies are defined like more than 6 mm thickness. Okay, so yes, we can differentiate on the basis of that. That is a very important it is very important to know, because in management perspective you have to manage accordingly. So coming to the topic proper, this is ventilator strategies in ARDS. I am again telling you that I will be focusing very basics. I will not cover anything like PRVC, APRB mode, lung recruitment, nothing. The reason being, what we have seen in our shifts is like some of the residents are putting on PRVC mode, but the next resident is unable to do that. So focus on one thing, because changing the ventilator strategies affects the patient more negatively than the continuously VCV mode. So we have to remember how to manage VCV mode at least. After that only we will go. This was my presentation, sir, in my second semester, where I have covered everything about recruitment maneuvers or inverse receive ventilation, but those things are not necessary unless we are covering the basic topics. So this was an article published in 2000 in NEJM about ARDS. This is by ARDS network, ARDSnet ARMA protocol, where they have found that 9% absolute reduction in the mortality was there with low tidal volume strategy. And we are reading COVID ARDS. So why I am focusing the same article again is like many studies, including this big review article, which have found that mechanical ventilation strategies in the classical ARDS and COVID ARDS is almost similar. You should not be worried about whether high PIP strategy to be followed, whether recruitment maneuver should be done or not. Basic thing is like we have to put the patient on VCV mode and how to start the low tidal volume strategy. Okay. Remember why this is important. I am again and again reiterating every single point is like for most of the patients in a ED, you have to follow this protocol. In some patients, for example, there are two categories of patients where this protocol should not be followed. One is patients with a completely normal lung and came in respiratory failure. For example, severe metabolic acidosis. You are intubating the patient, so you will not follow this protocol. Or, for example, a patient who is a COPD, acute respiratory acidosis patient. So, in a patient who has obstructive lung diseases, you will not follow those type of this strategy. So, for example, in large chunk of patients in our ED, we will be following this protocol. So you have to be very thorough about each and every steps. So this is low tidal volume strategy. First thing you have to know is like calculate the ideal body weight. This is another thing we have seen that no one is calculating ideal body weight. Everyone is thinking that every person is 60 kg. So Pradeepan, I don't need the formula. How ideal body weight is calculated? What is the variable that is to be taken care of? Height. Height of the patient is very important. Whether he is or she is obese or not doesn't matter. So how to calculate? This was I was doing in our red one. I was seeing how to calculate easily. So we have in our counter, we have a measuring tape. Doing it for once, height will not change. For a person, height will never change, at least for 10 days. So you, at least for the first time when you are managing a patient, just calculate the height and put the formula on a calculator. It has been seen that most wrong calculations has been occurred because of the calculation of the ideal body weight, and it has affected the lungs badly. Many of us have seen that so many patients of COVID ARDS had pneumothorax, bilateral pneumothorax, 2 ICDs in place. The reason, it is not like the COVID lungs is causing, it might be that we are causing the barotrauma. So we have to be very careful about the low tidal volume strategy, because the tidal volume is very important. Going for a very high PIP is not necessary. So focus on that. So simple estimation what we can do is like one red bed. All the red areas has a single style of beds, and it is like the red bed length is like 200. That black mattress length. So you can use a A4 paper if you don't have anything, and you can minus it out and you can see what is the ideal body weight. It is a simple way. Now after calculating the ideal body weight, you have to select a VCV mode. Yes, I am not going to PSV mode or anything else. You have to set the patient on VCV mode. In ED setting, you are intubating the patient. You are not getting a patient who is intubated. So select the VCV mode first, because that is the most easy method to do. Okay. And then we will be following the 4 dial concepts. So this is the 4 dial concept. One is tidal volume, one is inspiratory flow rate, one is respiratory rate, another is FiO2 and PEEP in tandem. We will be discussing everything. This is one slide. So this is one thing I was planning to focus on. Like we have different ventilators in different red areas. Even in our there are different type of ventilators. So I'll be focusing on single. I'll be showing images of our ventilators in our ED. How to set where are the 4 dials that is necessary. So this is the air liquid extend ventilator. This is TEMA ventilator. This is another ventilator in ECG room. It is there. We have used. Another is AGO ventilator. So this 4 dials, we should know where the 4 dials are there. Okay. So this is our common extend ventilator. So first you have to select the VCV mode, and there are 3 out of 4 dials are there. Inspiratory flow rate is only available in dragger ventilator. So apart from that one single dragger ventilator, all ventilators we cannot set all the 4 dials. So 3 out of 4 dials can be set. One is PEEP FiO2 1 dial, respiratory rate and tidal volume. 3 ventilators, 3 dials can be set. Similarly, this is the TEMA ventilator. In TEMA ventilator, this is the VCV mode. You have to rotate it to get it to the VCV mode, and here FiO2 is fixed. So here you can set tidal volume, respiratory rate, PEEP and FiO2 you cannot go in tandem. So TEMA ventilator is not very great in managing ARDS patients if they are not very severe. Because if the patient is very severe, for example, if the patient is requiring more than 12 or more than 18 PEEP, then only this 100% FiO2 will be helpful. But we don't have, so if we in a resource limited setting, we have to use this. Then another, this is the AGO ventilator, where you have to select the VCCMB mode, and here also we can set 3 dials like PEEP FiO2, tidal volume and respiratory rate. Similarly, this is another small ECG machine type of ventilator. So here also you have to select the VCV mode, and here FiO2 is fixed. So only 2 dials can be set. You have to know your machine. Otherwise you cannot manage a patient. Waiting for a lab technician or OT technician is not desirable. You have to know, you have to manage the patient at that point of time. Okay. So coming to the ventilator strategies in ARDS, again the 4 things. One is the tidal volume for lung protection, inspiratory flow rate for comfort, respiratory rate for ventilation out of carbon dioxide, and FiO2 PEEP for oxygenation. Now, what are the goals? Remember this, because I will be asking everyone. So remember these things. So what are the goals for tidal volume? The goal is the plateau pressure. So we have to titrate the tidal volume according to the plateau pressure. So plateau pressure should be less than equal to 30 millimeters of mercury. Coming to the inspiratory flow rate, you cannot change, so don't worry. In case of respiratory rate, it is 16 to 18 per minute, and the goal is pH. Please remember, the goal is not CO2. Please remember, goal is not EtCO2 or PCO2, it is pH. Then in FiO2 or PEEP in tandem, what is the saturation goal and what is the PO2 goal? Though in COVID ARDS it is different. In COVID per se, in WHO what they have defined in COVID is 92 to 96% of oxygenation. But these things has come up from the ARDS trial. So following this will be better than expert consensus based 92 to 96. Okay. Now coming how to check the plateau pressure. How to check the plateau pressure? In extend venti, you can put a pause of inspiratory pause of 1 to 2 seconds, and then you can get a P plat measurement window. Sir, the reason WHO when the WHO guidelines came in the early in March April 2020, they have just gave it on the basis of consensus. They have not this 88 to 95% has come up from the ARDS net trial protocol, but such a bigger trial has not been conducted in COVID ARDS per se. So they have given this. Yeah.
So why didn't they follow the ARDS net criteria rather than setting up their own consensus base, which was because ARDS net is evidence based.
Yes, sir.
And so what is your thought on that? Because it was
actually ARDS net protocol came in 2000.
Yes, sir.
After that, lot of research was done and lot of randomized control trial was done. So one trial was oxygen ICU trial, second trial was closed trial, and the third trial was LOCO2 trial, liberal oxygen versus LOCO2 trial, that is liberal oxygen versus conservative oxygen therapy in ARDS patients. So they came to a conclusion that you have to keep it slightly on the higher side.
Okay.
For example, you said that it is 50 to 80% of PO2 and then 88 to 92%. But if you keep between 92 to 96% and it is somewhere around 80 to 90 PO2, then the 90 days mortality was slightly better, and less number of patients actually developed some complication. Like if you keep it on the lower side, there was increased risk of mesenteric ischemia. A lot of patients develop mesenteric ischemia, sometimes myocardial infarction, sometimes stroke. So now there is a concept that you can keep PO2 slightly on the higher side and the SpO2 is slightly on the higher side. Maybe we can do further research, but lot of evidence is there.
Okay, sir. So
they say that 92 to 96 keep it and around 80 to 90 CO2. And the evidence is oxygen ICU, close, LOPO2 trial, LOCO2, conservative oxygen.
So we'll be following then SpO2 goal of 92 to 96. Now again coming back to the how to check the plateau pressure. So here by putting an inspiratory pause you can check the plateau pressure. So the plateau pressure goal is equal to less than equal to 30 millimeters of mercury. That is very necessary, otherwise it can cause barotrauma. So if P plat is less than equal to 30 millimeters of mercury, you can start with 8 ml per kg. Just for standardization, you can start with 8 ml per kg. If P plat is less than 30 millimeters mercury, you can decrease the tidal volume by 1 ml per kg till 6 ml per kg. Similarly, if P plat is more than 30 millimeters of mercury, yes, you have to decrease down. So decrease the tidal volume by 1 ml per kg till you can go to 4 ml per kg. The problem that happens here is like hypoventilation. If you are decreasing tidal volume so low that it can cause PCO2 retention. So if CO2 retention is there, no need to worry. You have to focus on pH. So if P flat still remains very high, always rule out auto PEEP. I'll tell you how to do. Rule out the patient ventilator asynchrony, check for pneumothorax, check for mucus plugs, and in obese patients, yes, you may consider a P flat goal of slightly higher side, like 35 millimeters of mercury. If the P flat is less than 25, and still you can go tidal volume up to 6 ml per kg, but this happens in a trend, means this is not like that you start with 8 ml per kg, then how you can go up to 6 ml per kg. You have been down titrating and then you found that P flat has dropped down below 25, so you have to increase till 6 ml per kg. Okay, to maintain a P flat of 25 to 30 millimeters of mercury. So a rapid revision. Golak, tell all the 3 points. Mike. Okay, great. The point is here is like how to titrate, means what is the duration. In ARDS net protocol they have told that it should be, yes you can sit. In ARDS net protocol they have told that you can change the tidal volume within 2 hours. So for example you can change the tidal volume, for us we can take like 1 hour, 30 minutes to 1 hour we can change the tidal volume. This is one thing. Then second thing is respiratory rate. 1 hour later. What they have in protocol they have told that less than equal to 2 hours you can change, but what early they have not told. Yes sir. So I could not get the particular, so I am telling like 1 hourly we can check. Yes sir. So every 30 minutes. Hourly. Then coming to the respiratory rate. Respiratory rate is to be titrated according. Any question? Okay. So respiratory rate should be titrated according to pH, not according to the PCO2. pH goal is 7.3 to 7.45. It is also not 7.35 to 7.45. It is 7.3 to 7.45. The settings, initial respiratory rate should be set as a pre-intubation respiratory rate or from the previous NIV settings. So how to check? Most of the patients are on NIV. Then we are planning for changing to intubation. We are going to intubate the patient. So you can get the respiratory rate from the right sided parameter. Okay. So what is the patient's respiratory rate? Then we can set the respiratory rate like that. So pH is, these are not mathematically correct, but just to remember, pH is directly proportional to respiratory rate. So if you are having a low pH, so low respiratory rate, so to increase the pH you have to increase the respiratory rate. That is a simple thing. So if pH is between 7.15 to 7.3, what you have to do is like you have to increase the respiratory rate until the pH has come above 7.3 or PCO2 has dropped down below 25 millimeters of mercury. If the pH is less than 7.15, you can increase the respiratory rate up to 35 per minute, because 35 per minute, after that ventilator is also not allowing, and that is not physiological. And even after reaching the 35 per minute respiratory rate, if you are not getting the pH goal of 7.15, you can increase the tidal volume by 1 ml per kg. This is second thing. Third thing, if this is also not happening, you can go for soda bicarbonate. So I'll tell you one important thing here. So many patients we have seen going into acute respiratory acidosis in our lung protective ventilation in our patients. So why? What we can do? So remember that when you are increasing the respiratory rate, you have to rule out one important thing. The patient is not having obstructive airway disease or patient is not obstructing. So auscultate the chest for wheeze, not possible in PP. You can check auto PEEP. How to check auto PEEP? You can check auto PEEP from the flow time curve. That this is the inspiration curve. When the patient is expiring, it is not reaching the baseline. That means some amount of air is getting trapped inside the lungs. Then again the ventilator is giving an inspiratory breath. So again the patient is getting an inspiratory breath, and then again the expiration will not be reaching the baseline. So before increasing the respiratory rate, any patient who is having a raised PCO2, you have to check whether the patient is having auto PEEP or not, whether the patient is having wheeze in his chest or not. If it is there, you have to give bronchodilators, you can do suctioning. Even if even you can increase the expiratory time, you might be knowing about the obstructive lung strategy, so you have to follow the obstructive lung strategy, like increase the expiratory time to 1:4 to 1:5, may decrease the minute ventilation, even you might need to decrease the respiratory rate. So this part I am leaving aside because this is a completely different obstructive lung strategy. We can discuss at the end what is an obstructive lung strategy, but remember, you have to, before increasing the respiratory rate in both the cases, we are planning to increase the respiratory rate in both the cases. So before you are planning to increase the respiratory rate, you have to rule out auto PEEP, you have to rule out wheezes. So if auto PEEP is absent, you can follow the goal pH, and the concept of permissive hypercapnia persists here. So what is that? So what is permissive hypercapnia is like the patient is in a patient of ARDS, it has been found that respiratory rate acidosis is well tolerated. And a benefit of high PCO2, yes, there are some benefits that has been found in basic science studies, like it reduces the respiratory drive, patient ventilator asynchrony is reduced, it attenuates the ventilator associated lung injury. These are the findings of the studies. And PCO2 means the carbon dioxide has some anti-inflammatory action. So permissive hypercapnia is allowed. You have to focus on pH, not PCO2. But what happens if you have increased the respiratory rate to 35 per minute, if you have increased the tidal volume by 1 ml per kg, still you are not getting a pH goal of 7.15. So what you can go for is like sodium bicarbonate infusion. There are some contradictory evidence regarding this, but ARDS protocol we are following. In ARDS protocol, what they have told is like in case of severe acidemia, even after controlling all these variables, if you are unable to reach the pH of 7.15, you can give sodium bicarbonate boluses. Sir, any so this is one thing. So we have been finding so many patients with this acute respiratory acidosis in low tidal volume strategy. So please follow this. Even you can give sodium bicarbonate so that the PCO2 can be washed out and pH can be raised up. Okay. Remember, the patient should not be in severe traumatic brain injury. Akhil, why? Why permissive hypercapnia or all these concepts should not be applied in severe traumatic brain injury? Why? How? If PCO2 is raised, what will happen if PCO2 is lower than the normal physiological cutoffs? What will happen? In which side? Means PCO2 raised or low PCO2? High PCO2 or low PCO2? Yeah, correct. Slightly. Someone else. Fawaz. Again, Vinayak is not listening. Again, loud.
Actually, carbon dioxide will cause cerebral vasodilation, which will cause increased blood flow to brain, which will increase damage to already damaged brain.
How? If it increases blood flow, how it will damage? It increases the ICP. If PCO2 is low, then if PCO2 is lower than the physiological cutoff, like 35, it is lesser than that, what will happen?
It will decrease cerebral blood flow, so
it can cause ischemia. So for that reason only, this permissive hypercapnia concept is applied in all cases except in severe traumatic brain injury. Okay. Now, so we have we are focusing on the second dial. So pH 7.3 to 7.45. If pH is more than 7.45, yes, you can decrease the respiratory rate till you get a pH of 7.3 to 7.45. This is simple. So again, revising this, Archana. So everyone is clear, our first semesters and second semesters, because most of the time you are managing so many ARDS cases. In last 4-5 months you have been managing so many ARDS cases. So please remember that these small things matters. Okay. Now coming to the fourth dial, that is PEEP FiO2 tandem. So we will be focusing on 92 to 96% saturation goal. So during intubation we have intubated a patient with a FiO2 of 100%. Now you can drop down. Remember how to do that. To apply a PEEP FiO2 tandem, there are two ways. You can either down titrate from 100% 24 millimeters of mercury PEEP, you can down titrate, or you can up titrate. For a safer strategy, don't increase the PEEP to 24 and then come down. What you can do is like incrementally you can do. One thing you have to remember, that once you change the setting, at least 10 to 15 minutes is necessary for oxygen to have a equilibrium. So it's not like that you have increased the PEEP to 5. Oh, SpO2 is not increasing. Chalo, just increase the PEEP to 10. SpO2 is not increased. PEEP to 18. It is not like that. You have to give time for recruitment and you have to give time for oxygen equilibrium. So 15-20 minutes should be necessary. Means after changing a setting, at least you give a 15 minute. You let the patient get equilibrium with all this oxygen and PEEP, and then you change. So what is a tandem? So once you intubated a patient, you are intubating a patient with a FiO2 of 100%. Now you can decrease down by standing near the patient only. You have to decrease down the FiO2 to 40% so that you can stand in a PEEP FiO2 tandem table, and then maintain a PEEP of 5. I'll tell. So what happens is, this is the PEEP FiO2 tandem table. So here you are. For example, we are maintaining a PEEP of 5. When you are intubating, PEEP of 5 is set, and here 100% FiO2 was there while you are intubating, because you are pre-oxygenating with 100% oxygen. Then what you can do is like, suddenly you can drop down the FiO2 to 40%. If you are worried, you can drop down to slightly on a higher side also, but you have to stand near the patient. It's not like that intubate kar liya aur chalo chalte hain. That is not a point. So once you drop down the FiO2 to 40%, then you have to follow the PEEP FiO2 table. So you are standing here now. So from 0.4, if at FiO2 of 0.4, PEEP can be raised from 5 to 8. So at this, you can raise the PEEP of 5 to 8. Then after that, you can increase the FiO2 to 0.5. Then again you can increase the PEEP from 8 to 10. Similarly, this is the table that has to be followed up. Easy way to remember in bedside. Yes, we can remember like PEEP is equal to FiO2 into 20. This is just a vague thing. What you can do is like, see, this is 0.48. So for a FiO2 of 0.4, yes, you can go up to 8. For FiO2 of 0.5, you can go up to 10. Here it is not matching. For FiO2 of 0.7, you can go up to 14. Similarly, 0.9, 18. So this is wrong. One thing is wrong is here is like, we are giving oxygen 100% and we are giving a PEEP of 5, and why the patient is not improving. So PEEP and FiO2 has to go in tandem so that lung alveoli is getting recruited. So that was the most important concept of ARDS net protocol. So PEEP FiO2 has to go in tandem. So in TEMA ventilator you cannot set like that. Yes sir. So it will not help out. It will not help out. So it will not help out. And another thing is, what is the concept of baby lung? We will tell you. Aditya, what is baby lung?
So what happens in severe ARDS, like we have patients who alveoli are severely affected and damaged, maybe due to atelectasis, which may be due to either if you are giving if the alveoli are damaged, maybe due to barotrauma, volutrauma, any due to inflammation. So these alveoli are actually, they are not working now. So these alveoli essentially they don't participate in ventilation. So the healthy alveoli, on other hand, there is a small population of healthy alveoli which are remaining. So what happens is, these alveoli, the healthy alveoli, what we are doing is, if we give the same tidal volume according to the ideal body weight of the patient, without considering that the patient is in severe ARDS, we are giving a higher tidal volume to the patient. So the whole tidal volume is going towards the remaining alveoli, not all the alveoli. So what happens is, the remaining alveoli have to bear the brunt of all the tidal volume.
Correct.
Which may lead to further volutrauma or barotrauma. So the concept of baby lung originated in which only a few handful of alveoli they participate in the whole gas exchange. Like baby's lungs, despite the whole lung, only a small portion of it is working.
So everyone is clear. So because of that only low tidal volume strategies have come out. Okay. As Dr. Aditya said, it is yes, there are small population of alveoli which are normal. So if you are giving a large tidal volume according to like for example 10 to 12 ml per kg, if you are giving for a patient who is, you must have seen in your anesthetic posting in MBBS, it is 10 ml per kg or 12 ml per kg we used to give a tidal volume. But why not here? Because they are having normal lungs. Patients are having normal lungs in general anesthetic condition most of the time. So if you are giving 10 ml per kg, the small alveoli whichever are normal will also get volutrauma and those are also getting destroyed. So that is the concept of baby lung. Not going into details of PRVC, APRV, inverse ratio, high PEEP, HFOV. I am telling these terms because there are so many other ventilator modes in ARDS that exist. Why I am not sir. Yes, sir. So, as Bhoi sir has asked, how many of us are following this? I'll tell you before raising your hand. I'll tell you one thing. How many of you are religiously following includes waiting for 10 minutes? Okay, it's not like SpO2 ke dekh ke just we are changing the PEEP. How many of you are religiously following this? Seena, Surya, Devant, Archana. First thing, what are the problems? Why Rakesh, Aditya, you are not following? Any major reason so that we can devise what are the problems? What are the problems that we are not being able to follow this? Okay. What are the hindrances to this? Anyone can tell why you are not following? I have been following this since my second semester, but why we are not following? Everyone is not following. Can be done. Yes, sir. That can be done, sir. We can add a pro forma like thing so that we can follow this. Yeah. So the problem that he has told, I'll share these things again. Means I have photos of that, how to combat that thing. So what he is telling for everyone, Vinayak, you are listening, no? So what he is giving a problem is like most of the times the compressor is not on. Okay, the air compressor. Ventilator is set to give a FiO2 of 100, whatever you are setting. Okay, by default it will give a FiO2 of 100%. Only oxygen it will provide because it is connected to the 100% oxygen supply. Now to get a supply of 50%, you have to remember that it has to be connected to a oxygen port, to an air port. Okay, means air, the port of air. There is a black port. The port of air should be there. It should be connected. The ventilator should be connected to two ways, to the port of air on the wall mounted port, or it has to be connected to the compressor in the below. So I'll show the photos how to do that, because most of the times we are missing. Yes, we are not seeing the alarm settings. So maybe later on we can read on all the alarm settings here. So today I'll discuss at the end of the class. So we'll focus that how to on that. Now point is like why I am not focusing all these things, because changing the shifts, changing ventilator strategies affect the patient more. Please follow one single protocol universally. Then only we can go to PRVC mode at least. Then we may try APRV. Very less subset, very small subset of population may be needing this. So follow VCB mode very tactically. Then coming to another most important part is sedation and analgesia. Better tolerance of mechanical ventilation is there if the patient is well sedated. It decreases the oxygen consumption. You everyone must have seen that. Benzodiazepines and opiates are can be used, and use of some scale can be used. Rahul, what are the scales that can be used for sedation of an intubated patient? Boys are asked every time. How? If you are sedating a patient who is an intubated patient, what is the Richmond agitation sedation scale score to be followed? Means what is the cutoff? Means what is the range? RAS should be what? It is the whole range. So for an intubated patient, what should be the goal? No. What is the goal? Raj Lakshmi, what is the goal? RAS goal. It is -1, -2. So -2 is the goal. So it has to be followed also. The patient is fighting or patient is completely knocked off. That is not necessary, because patient has to recover also. So follow this Richmond agitation sedation scale also, and in a ARDS pro forma we will also try to add this also. Okay. Then another thing, this is just a table I have added, and I'll share the presentation where I have written the dosage which we can use or which our nursing sisters are using. So which dose we can use directly. Now neuromuscular paralysis, then this is another thing that we have been doing incorrectly, that is neuromuscular paralysis. It is not for all and not forever. Many patients are getting neuromuscular paralysis, cisatracurium infusion for 5 days, 6 days, 7 days. Many patients who doesn't need, only cisatracurium infusion is going on and there is no sedation. So you are understanding, no, you are paralyzing the patient but he is conscious. Okay, so that is yes sir, that is very traumatic. So only it has to be started when the appropriate analgesia and sedation has failed. In patients with severe ventilator asynchrony, even after adequate amount of large doses of sedative agents or analgesic agents have been given, then only go for NMB. What are the trials? Accuracies and Rose trial have come up. So in a patient who is having a PF ratio less than 150 millimeters of mercury at PEEP of 5, cisatracurium infusion can be continued up to 48 hours. It's not like that 5 days, 7 days it is going and nursing counter sister is telling that cisatracurium has been finished. Okay, that should not happen. It should be continued for 48 hours. Once you start NMB, you have to take care of some important things. Proper sedation and analgesia is always to be taken care of. Prevention of corneal injury, we are not taking care of that. See, in our ED, we have been seeing so many patients who are lying down. So prevention of corneal injury is an important part. Close monitoring of ventilator disconnection, because once the patient is disconnected and you have knocked off, you know. Prevention of bed sores and venous thromboembolism prophylaxis are important. These are the dosings you can see later. Nutritional support, after 2 days or 1 day you have to start with. Patient should not die of starvation at least. So you can elevate the backrest 30 degree, and with a large bore NG tube or OG tube you can give standard enteral feeds. Everyone knows that our patients are getting enteral feed nowadays in ED. Everyone is aware of that, no? And it should be given 50 ml every 2 hourly. The patient relative can give. In ED that is there. Okay. Okay sir. So steroids and cardiac arrest, this is whole different discussion that we can have. Remember one thing, every time in one shift injection dexamethasone 6 mg OD, Second shift, injection dexamethasone 8 mg BD. Third time, injection dexamethasone 20 mg BD followed by 10 mg OD for 5 days, 5 days. Then injection methylprednisolone. For a single patient, if you see a case sheet, every shift it is getting changed. See, recovery trial is a big trial. It is very, very vast trial. So following that protocol is very important. Now we are seeing cases of many secondary infections. Rise in mucormycosis case we will be discussing. So because of that rampant use of dexamethasone, if the trial has come up with a dexamethasone dose of 6 mg, why should we give 20 mg? There was a trial, ARDS trial, which has come up in 2018, which have shown that in ARDS 20 mg OD for 5 days followed by 10 mg OD for 5 days is useful. But recovery trial has come up. So give a 6 mg IV OD. What is a problem? Giving a uniform management is more important than changing things. Similar to the ventilator strategy, follow a single thing. Okay, follow 6 mg IV OD for 10 days. This is another thing. For many patients in HFNC, we have patients like for 17 days, 18 days. They are getting dexamethasone continuously. It has to be continued till 10 days or till hospitalization, which is shorter. It is not like 17 days we will be giving dexamethasone and then the patient will be developing hyponatremia, patient will be developing fluid overload, patient will be developing. There was some wrong. In some patients it was there, sir. Then we have stopped. So please follow after. We are going to get third wave also. So please follow one thing. Please follow at least evidence-based medicine guidelines. If they have come up, most of the international guidelines is following this, so we have to follow this. Please don't change according to, if you have read, see, today 13 trials are there, 13 big randomized controlled trials on steroids in COVID ARDS is there. But no one is so much strong like a recovery trial. So following that is better. It has to be done. Means it is not desirable, it has to be done. Otherwise patient is getting hyperglycemia, you are not controlling the glucose and then patient is going into decay. Some days later he or she might come up with mucormycosis. Other supportive care, glycemic control is very necessary. Stress ulcer prophylaxis, peptic ulcer stress ulcer prophylaxis has to be given. Every patient is getting that. Fluids, conservative fluid management and managing the septic shock according to the septic shock protocol. DVT prophylaxis. What antibiotics to be followed? That is another thing. Every patient in every shift getting different antibiotics. First the patient will get a piptaz, then the patient will be added with an piptaz and azithromycin, then it will be meropenem, then someone will come to ceftriaxone azithromycin, then another person will come who will decide we should not give antibiotics because this is a case of COVID ARDS. That should not be the protocol. Okay, so we have to follow what we have started and why you have started. Why you have started piperacillin tazobactam or why you have started just with ceftriaxone and azithromycin. Write it. Always write why you have started so that the next shift person should follow that, and you have to tell them please don't change it unless it is indicated. Okay, it is very important. Oral hygiene is an important thing to be considered. What we have seen is like in Red 2, one patient was lying for 4 days intubated, and again the patient extubated himself and we are going to intubate the patient and we found full mouth is full of fungus, white fungus completely. So the patient relatives are staying, so give them a cotton, tell them to get a betadine, they can clean it always. They can clean or brush like twice daily, because in ICU sister ji used to do brushing, so why can't the relatives can do? Okay, we have to tell that. Documentation, this is another thing which we are lagging at. We can find some other important points also here. So what we can do is like, what is the diagnosis, what is the ventilator setting at present. For example, at 4:30 am, what is the ventilator setting? At least the 4 dials you can write, and why you have changed to this, because the saturation was lower. Okay, why you have changed to this, and titrate according to the SpO2 after 15 to 20 minutes. You can write like that, or if we are making a proforma, we will be attaching that, so we will be following that. So at least this has to be done also, because someone is coming and changing, then another SR will come, he will change, another JR will come, he will change. So that should not happen. Few literature review, these are not necessary. There are so many trials that has come up, and some things are strongly favored, some things are strongly against it. Last 5 minutes, again the same thing. We'll start with Vinayak, Berlin definition, jaldi. Tell both. What is the most important comments here and what are the important points that has to be added?
Timing between onset of 7 days of onset of symptoms,
Or worsening of symptoms within 1 week.
or chest imaging, bilateral chest positives suggestive of ARDS, which is not explained by consolidation or
Consolidation will be there.
not explained by atelectasis.
Not explained by effusions, lung collapse or nodules. Cause of edema should be
Non-cardiogenic.
non-cardiogenic. And what about oxygenation?
Oxygenation PF ratio less than 300 at the PEEP of minimum PEEP of 5.
Or a CPAP of 5.
PEEP of 5.
Then coming to Sri Devi, tell about P-plat.
Sir, tidal volume should be maintained 8 ml per kilogram, and it should be titrated according to the P-plat. And if the P-plat is less than 30, then the target is P-plat less than 30. And if it is not less than 30, then we can decrease the tidal volume 1 ml per kilogram. And when the P-plat goes below 25, then we can increase the tidal volume by 1 ml per kilogram.
Correct, you're correct. Then respiratory rate, Yatharth.
Respiratory rate has to be titrated according to the pH.
Not according to PCO2, please. It is not according to ETCO2 or PCO2. Then
The goal pH is 7.3 to 7.45. If the pH is between 7.1 to 7.3, we have to increase the respiratory rate. Maximum we can go up to 35. If even after going up to 35 the pH is low, then we can increase tidal volume by 1 ml per kg. And if even after doing this it is not maintained, then we can give bicarb bolus.
sodium bicarbonate. Radhika, what is the most important thing before increasing the respiratory rate you have to take care of? Use mic and tell. Before increasing respiratory rate, what is the most important thing you have to see?
Minute sensing.
No.
Auto peep. Auto peep.
Auto peep. The patient should not have wheeze, patient should not have auto peep. Correct. Then coming to the PPFI2 tandem, that we know everyone has to follow the PPFI2 tandem. Thank you. Thank you.